a thumbs up and I'll go.
Welcome everyone. We'll just get started in about a minute here.
So, in einer Minute geht's los.
Hello and welcome everyone to the fourth installment of the COVID-19 webinar series hosted by the Joint COVID-19 Task Force. The topics being presented at the webinar today include the cytosorb use, care team's perspective, and transporting COVID-19 patients on ECMO. We are very thrilled to host perfusionists and surgeons from Switzerland and the Netherlands. In this webinar, we will hear from Maximilian Halbe, a perfusionist from the University of Zurich in Switzerland. He will share his hospital statistics on the COVID-19 patients and the use of Cytosorb on this patient population. We will also hear from Dr. Roberto Lorusso, who is an associate professor in the Department of Cardio-Thoracic Surgery at the Heart and Vascular Center at Maastricht University Medical Center in the Netherlands, and he will be describing the EuroELSO statistics. Our final speakers will be Koen van Tilburg, a perfusionist, along with Dr. Martin Schmiady, a cardiac surgeon from both the University of Zurich, Switzerland. They will share their experiences transporting COVID-19 patients on ECMO.
Hi, I'm Renee Dickey from Seattle Children's Hospital. I'm one of the moderators for today. That was Dawn Oles, our lead-in. She is a program director for Vanderbilt University Perfusion Program in Nashville, Tennessee. Our third moderator is Shelley Brown, a perfusionist from Allegheny General, Pittsburgh, Pennsylvania. We will be recording today's broadcast to allow for future playback. After presentations, we will use a question and answer session to answer all of your questions that we can get to. Please feel free to use the Q&A function at the bottom of the Zoom presentation window to submit any questions you may have during the presentation. And we will do our best to answer as many questions as possible.
If we are unable to get to your question, please consider using the Joint Perfusion COVID-19 Task Force discussion forum to submit your question. Members of the task force are monitoring the discussion forum and are working to answer as many questions as we possibly can. We are happy to announce the ABCP has approved today's webinar for up to 1.5 Category 1 continuing education units for those participating in this live broadcast. Attendees will receive a link to a survey within the next 24 hours. Certificates will be sent within the next 3 to 4 weeks. We'll start today with Maximilian Halbe.
Hi, everybody. Hi from Zurich. Happy Perfusionist Week to everybody out there. I'm happy to share our experience here from Switzerland, together with my colleagues Koen van Tilburg and the cardiac surgeon colleague Martin Schmiady. And I'm also happy to have my dear friend Roberto Lorusso on board, who will show you the number of the European survey, which was created by himself. So first of all, I would like to show you where we are. We are here in the middle of Europe with a wonderful landscape in Switzerland. We have 7 o'clock in the evening. Let's show why we are in a so calm situation as we are. We have today no patient on ECMO for COVID-19. And also the population is very safe in Switzerland. Maybe I think it's one of the reasons is the density of our country. I just during the preparation of this lecture, I compare Switzerland with a big city in US, Chicago, one of my favorite city I like very much. But the population is the same, 8.5, 8.7 million people. And the density in Switzerland is 207 people per square kilometer instead of the density in Chicago is 22 times more. So maybe that is one of the reasons why we are so safe and thanks God until now in a good situation in Switzerland. Let me tell you the story of the university hospital situation for COVID-19. 25 of February, we had the first reported case in Switzerland. Until 25 of February, we have a normal situation in our hospital with 8 ECMO machines and around 20 oxygenators always available in our ECMO center, the University Hospital of Zurich. Then after the first case get published, the decision was taken by our CEO, Professor Gregor Zünd, and my boss, Professor Francesco Maisano, the director of the cardiac surgery department, to order more ECMOs as much as we can. They told me order 12. I was able to order 23 ECMO machines, and we stocked up our ECMO oxygenator and cannula stock, as you can see, with 150 oxygenators and more than 300 cannulas. Here's a big thank to the companies which support us very well, and due to that, we built up a network in whole Switzerland with our colleagues, our great partnership and our great networking with all the other ECMO centers, which is Lausanne, Basel, Bern. And we had something like a WhatsApp chat. If somebody needs more ECMO machines or oxygenators, we can provide them always. Then 28th of March, the first COVID ECMO, I guess it was a transport. My colleagues, Martin and Koen, will tell you about our transport situation for COVID patients more in a minute. But as you can see, 28th of March, 29, 31, 1st of April, we had every day one COVID on ECMO implantation. So we start to get nervous, but thanks God, we are in a calm situation. And then on 17th of April, we were able to wean our last ECMO patient on COVID. But now I ask the question also to you, we can discuss afterward, what will be tomorrow? We can compare, maybe we can compare the situation with the Spanish flu. I mean, it's 100 years ago, but the curve I'm a bit afraid if this will happen the same as our grandfathers and grandmothers get faced 100 years ago with a very low first wave and then the second wave, as you can see. That is my recommendation. Don't lose up the situation. Be prepared for the worst case. And yesterday I also had a very nice webinar, and one of my colleagues from the Netherlands or from Belgium, Lean, told me preparedness undoubtedly has an impact on the outcome. So that is true. Be prepared. I will just show you quickly our numbers in Zurich that you can see we have a lot of experience in ECMOs, but also in transports. You can see the transport numbers in the yellow boxes, the black numbers. We have a lot of VA experience, but now we get faced with a lot of VV experience, but it's also very tricky, as my colleagues will tell you in a minute. We did studies with that, and the very big study is running right now with all ECMO cases since 2006. What happened with the mortality? Just a short view to the things we changed in the year 2014 and 2015. So there were recommendations by the society. All of you know that better than I do. Then we had the ECMO systems 2.0. First, we were only able to measure flow and rounds per minute. Now we are able to measure everything, temperature, posadium, everything. The pressure, which is very important also in COVID patients. We built up a transport service, a very successful transport service. We established the ECMO certificate for all of our surgeons. That means if a surgeon would like to implant the cannula, they need to receive a certificate. And we have an early start with the hemoadsorption Cytosorb. I will show you how we do that. Here I just want to present our experience for transport. In the last 6 years, we did more than 165 transport, and we reached more than 22,000 kilometers. We also do international transports with the jet, and that means you need to have a strong partnership. You know this picture, the first successful ECMO was done by Dr. Hill and Dr. Bartlett in San Francisco, 1971. You can see the machines, there's a big change from one machine, which was the whole room was filled, and now we have a very well-established transport solution, which you can see also on the pictures. If you have a transport system, you need to present everything. We did children's, the combination getting more and more interesting, and also we did a heavy transport with a BNI of 78. Yeah, for the COVID ECMO transports, especially my colleague Koen will tell you how to protect yourself and how to protect your stuff. I think that is a very, very important thing during this transport. That is my recommendation. I'm also a member of the steering committee of the EuroELSO. Don't create the ECMO transport service nowadays, because for COVID-19 patients, you need special ECMO transport experience. But if we have a patient implanted out of our hospital, we have something like a timeline. And now I would like to change from transport and overview to the Cytosorb experience in our unit. As you can see, in the first 2 days, we have a strict timeline, like you need to check the status of the brain, do a CT scan, do X-ray of the cannula position, restore the circulation, reduce and wean the inotropes and the vasopressors, and also eliminate the cytokines. Then in the second weeks, all of you know that, you need to decide which type of therapy, of treatment needs the patient in advance. But let's have a look for the Cytosorb therapy, the elimination of the cytokines. I don't want to have a focused look on the implantation of the cannula. Our surgeon, Martin, will do that in a minute. But in 100% of our COVID patients, we did 17 French cannula in the right jugular vein and 23 French cannula in the right femoral vein to support the patient like that. And if you have it, you can see it on the picture, how we treat or how we implant the Cytosorb. We bring out the blood for the adsorber after the oxygenator, because there's the highest pressure. So you can have it like a bypass, and you can give the blood back before the pump, where you have the low pressure, most of the times the negative pressure. For sure, there is an off-label use, because you know that if you use, for example, the CardioHelp system, you need to change something in the circuit. But I tell you, we have more than 700 treatments with Cytosorb in the University Hospital of Zurich, not only in ECMO, but also for CRRT or for the heart-lung machine. But if you do it on ECMO, you need to change something. But it's very easy. You just need a 3-inch connector with a Lorusso connection for a high-flow and 3-way connector, and a couple of things, as you can see here on the picture, and then you build it up very easily. We always have it like it is. So there's a very easy plug and play, very safe tool, the Cytosorb. Now some experience from our colleagues here, from Professor Lees. You can see it's one of my favorite pictures or slides when I talk about Cytosorb. You can see the start of cytosorbents. It's very early, so after 4 hours of the treatment, and you can see very nicely the vasopressin, the noradrenaline, and the adrenaline was weaned very, very well and very quick. There's a new study published last week from a German group, from Professor Alki. You can see here, so there was a combination of ECMO and Cytosorb in a severe pneumogenic sepsis. They all have, like we also had, always a high flow veno-venous ECMO. That means you have more than 10% of your calculated flow to treat the patient. But you can see here in the control group with ECMO, but without Cytosorb, the CRP levels like very high also after 72 hours. In the Cytosorb group, you can see it's decreasing very smoothly and very, very nice to see. Also, the catecholamines, you are able to wean very quickly. After 24 hours, you nearly have 0 catecholamines. And I mean, that is at least what we, from the perfusionist side, would like to have. We would like to have completely control of our patients, and as less as support you need with pharmacy or with other treatments, as better you can support the patient with your ECMO. A quick overview about the potential indications for Cytosorb therapy in ECMO or ECLS patient is the cardiogenic shock, after ECPR, the bridge to a VAD surgery just to have the patient clear without any cytokines. The RDS, as we are faced today, the severe RDS patient with a high volume of vasopressors demand, post-cardiotomy for sure, the infection, endocarditis, very nice treatment for the endocarditis patient on heart lung machine, septic shock, liver failure because of the removal of the bilirubin. And there are some other recommendations. The problem with Cytosorb therapy, there are not a lot of, so it's a very young therapy. There are not a lot of good studies available, but we have 2 in our pipeline. We have endocarditis, ECMO. We have 3 endocarditis, ECMO, and a type I dissection study running they look great, and we will publish as soon as possible. For all of you who do not have a direct contact to Cytosorbents, to the company, I guess in New York, they have their headquarters in New York. Here you have the email address and also the phone number. Please feel free to contact them. And with that, I would like to say thank you for the invitation by the Joint Perfusion Group. Let's build a network. Feel free also to contact me. Here you can see my email address. And now I'm very happy to give the word to Roberto.
Thank you very much, Max. Thank you. Should I proceed immediately? May I? Okay, so let's share the screen. So first of all, I would like to thank AMSEC for the very kind invitation, and of course, happy Perfusionist Week to everybody. You are so important for our activity, particularly in these very unprecedented times. I think that your contribution is so precious. So happy to share with you a few information. These are my disclosure. Just to tell you a little bit the history of what we knew at the beginning of the outbreak. This is the very first paper published in Lancet about 99 cases in Wuhan, as you know, the epicentrum of the outbreak in China. And if you look at the kind of symptoms this patient had, you can see that most of these patients had, of course, pneumological symptoms, so pneumonia, RDS, also some renal injury, but mainly these are respiratory symptoms. And if you look at what kind of treatment this patient underwent, you can see that ECMO was really limitedly used in the very first experience. But besides the respiratory symptoms, soon it became clear that it was not only that. And you can see that as compared to the previous virus outbreaks, COVID-19 is characterized often also by cardiovascular or cardiocirculatory system. And indeed, some publication appeared showing a clear cardiovascular compromise. And I will show you that particularly acute pulmonary embolism occurred almost in 20 to 30% of these patients. So this was really a frequent complication. But the impact of the cardiovascular compromise, particularly the cardiac injury in the outcome of this patient, is clear from another publication, always from Wuhan. And you can see the difference of outcome in patients with or without cardiac injury. You can see that patients who experienced cardiac injury had almost double mortality rate as compared to patients without cardiac injury. But then it came quite clear that as opposed to the experience in China, I would say to the east part of the world, that maybe ECMO had to be instead something really pressure in this treatment or the treatment of a COVID patient. So a couple of papers appeared in JAMA and Lancet to somehow give a warning about the potential, of course, help and useful and advantage of having ECMO. But nonetheless, there were a few publications. You can see another publication in Heart and Lung about the use of ECMO in COVID patients. And in this publication, they looked just a very, very limited experience in China. And they look at the actual impact of ECMO use in the treatment. And it was absolutely not relevant. I would say almost really futile in this very initial publication. And you can see here another publication from Brandon Henry, and he showed really something like a skepticism, and he really underlined, as you can see, a word of caution about the use of ECMO in these patients. But these same authors, so maybe he doesn't like at all ECMO, I would say, he published a little later on a Journal of Critical Care, and again, he underlined the poor survival of the patient undergoing ECMO if affected by COVID disease. And he just showed a very limited, you can see only, I would say, we have 17 patients overall with a mortality of ranging from 85 to 100%. And of course, he showed in a sort of a meta-analysis showing that the ECMO was somehow futile. So overall, the perception that at the end of February was perceived in Europe was that the ECMO in COVID patient was really not helpful, even contraindicated. But it soon became clear that that was not the case, because we had some experience from South Korea and Japan, and the numbers were, of course, still limited, but the survival rate was different. These are the numbers from South Korea and then Japan. And you can see these are published data, that the numbers were different from the Chinese experiences. So based on these, let's say, sort of a contradictory findings, we decided to look a little bit more. And this is the very latest publication. This was just appeared a couple of days ago from US. You can see there are some other experiences. The numbers are a little bit better as compared to China. And you can see this is the very latest publication in Asayo from a group of centers in US in 32 patients. And you can see again the preliminary data that we have in this situation more patient dying, unfortunately, than surviving, but still the vast majority was still on ECMO. But again, as you understood, there are a lot of controversial data. So we decided in Europe, and thanks to the EuroELSO endorsement and of course support, to create a so-called EuroECMO COVID working group. And this was started, of course, based on an initiative in Maastricht. And we made this study trying to collect as many centers as possible. And I will show you how this path was possible along the time of the outbreak. So we started, as you can see, to conceive the study at the end of February. So we arranged all the data set and so forth. So we launched this study the 15th of March. So after 1 week, we got 51 centers throughout Europe. And then the 1 week after, so you can see 28th of March, we got 74 centers. 1 week later, we went up to 96 centers. So you can see 4th of April. And then 1 week later, we achieved almost 120 centers. And the latest survey, we got, we had 132 centers, and the latest, the 26th of April, so 1 week ago, we achieved almost 150 centers, plus Israel, which join us, I think, with great pleasure. So we could have also a look not only in Europe, but also a little bit outside. So you can see a lot of enthusiasm about this initiative, a lot of centers sending their experiences. What about numbers? Because this is important. And you can see again, what a kind of rise we got along the time. From the 21st of March, we now reached, and tomorrow there will be the seventh week. So of course we will go over 1,000 ECMO. So you can completely understand and perceive that the situation is totally different from the Chinese experience. So we have now 150 centers with more than 1,000 ECMO implanted in Europe. What about the status? What about the results? Well, of course, these are very preliminary because, as you can see, the vast majority, 442 in the last survey, the last report, are still ongoing. But what we can say for now, again, very preliminary, so you don't have to take this as final data, final outcome. But apparently, the patient win from ECMO. This doesn't mean that they survive, but win from ECMO are certainly more than the patient who died on ECMO. There are a few patients who died after ECMO winning, but for the time being, we can see that the winning rate is a little bit higher than 50%. And what is also important and interesting from this data, you can see that along the weeks, the mean age remained almost stable, so quite young patient age, a little bit higher than 50 years of age, but particularly, again, what was found and confirmed from the very initial experience is the female gender is absolutely less impacted by the COVID infection as far as ECMO and COVID as compared to the male population. So based on this experience, we know that also US, then of course US now has experienced several weeks, a little bit on delay as compared to Europe, but the FDA reacted. As you know, there is now an enforcement policy for the use of ECMO in the treatment of COVID patients. So I think that what I can tell you, what we learned from this experience so far, because I think still a lot of understanding will come. The vast majority is veno-venous, more than 90%. We have just 10% between VA and VAV, but the vast majority is veno-venous. You shouldn't use double lumen because certainly the higher risk of thrombosis, but more importantly, you have the need of high flow, and the double lumen cannula cannot really provide and guarantee a high flow. So again, as I showed you, predominantly male and around 50 years of age. As I said, less than 10% of a different configuration. You should be prepared for sudden circuit membrane or pump head thrombosis, and then you have to use a little bit higher anticoagulation. You could have even on ECMO, acute pulmonary embolism. As I said, you could have also septic shock, and therefore you should prepare for even higher flow than what you expected. You could change the configuration along the run. You should expect also rather long support, 2-3 weeks. And what is very important, because as I showed you at the beginning of my presentation, there could be any compromise of the cardiocirculatory system. You have really to monitor closely this patient, because this patient can turn into myocarditis-like a situation or can have tamponade. So in conclusion, I think that we know that COVID disease impacts very severely lungs and also cardiovascular system. I think that the initial experience that we had as information from China was somehow misleading. And that was also the reason why a lot of centers were, I believe, unprepared or even skeptical to use ECMO at the beginning. But of course, we showed very clearly that now ECMO was really booming in Europe. And for the time being, again, very preliminary data, the ratio between weaned and death are around 50%. Of course, it is a very resource intensive. So in this situation of very, very difficult clinical management, ECMO can really put another burden, very high burden, but this is the situation. And I think that, as I mentioned, there should be some peculiar aspect in this patient, because this patient have a higher seals, a cytokine storm, so very prothrombotic state, so sepsis, and so forth. So you have to consider this situation. Thank you very much indeed for your attention.
Thank you, Dr. Lorusso. That was very interesting data. And next up, we have Koen van Tilburg and Dr. Martin Schmiady, who will discuss ECMO transport for COVID-19 patients. Thank you.
Yeah, thank you a lot for the very kind introduction. I hope everybody can hear me. My name is Martin Schmiady. I'm also a cardiac surgeon from the University Hospital in Zurich, and I will share the talk with my colleague Koen von Tilburg, who is a perfusionist in our department. And like Max was telling you in the beginning, we will talk a bit about our inter-hospital transfer program and out-of-center implant program for COVID-19 patients. I want to start the talk with a few numbers. So here you see the situation in Switzerland. So far we have 30,000 COVID cases in Switzerland, and you see to us the disease was coming more or less in the end of February 2020, and the peak was reached by April 2020, where we also start to perform our first ECMO implants in the hospital. And we also get the first calls from smaller hospitals around us who ask for help because they really had patients which were deteriorating fast and who were calling us to get support. So here maybe I will show you the numbers from our, or the data from our first 3 patients where we done an out-of-center ECMO implantation. Altogether, we had done 5 implants so far here in Switzerland. And all the implants, as I was saying already, were done in March of this year. All patients, as Professor Lorusso before also was pointing out already, were male. Yeah? So there was only 1 female under all the 5 patients we done so far. The median age of the patients was around 60 years, with the youngest patient 48 years old. And you see from the ECMO setting, in all patients we went for veno-venous ECMO. And what I also wanted to point out, that all of these 3 patients were more or less young patients, which has had before, they were in a general very good conditions with only veno or no comorbidities. As you can see in the slide, there was 1 patient who had a diabetes, another patient who had a little bit severe adipositas with a BMI around 40, but they didn't have other very big disease. So, of course, if you start now with such a program, you must be prepared, yeah? And we had the luck that we have experience with this ECMO transport for around 11 years. And I think I will give the word now to Koen, who will describe you a bit the start of the ECMO transfer program in normal non-COVID times. And then we will go to the special COVID situation back again and talk about our experience in the COVID-19 patients.
Good. Thank you very much, Martin. I hope everybody can hear me. This slide we already have seen, so the increasing numbers of ECMO transports in Switzerland, or actually at our centers. I think that is a great success because we invested a lot of time in this program, and that's the good thing, that we could raise the numbers and also have very good partners with other foreign hospitals, so that we can provide the best therapy for our patients also in other hospitals. Martin, can you skip? I cannot skip. Yeah, thank you. So before you start doing difficult transports with COVID patients, you probably should have a good ECMO program running for ECMO transport. And that's a small slide where you see what you all need for that. So you actually, or here in Switzerland, we need also always a perfusionist for that. We need a surgeon who actually will implant our cannulas for that. You need always a prepared ICU unit who is willing to take all the patients, all the ECMO patients, also from foreign hospitals. You have, or your service should be possible 24/7. The ECMO patients will come at the baddest time, if you know it. And so if you see here, it's a small circle actually. So we usually have a telephone conference with another hospital where you see, does this patient actually need an ECMO, or is he already on ECMO and he has to go to an ECMO center? Or is it maybe another device like Impella or ERBP? Then we do clarifications of the resources. So we will go and plan the transport. Usually it's planned by the perfusionist, and then we go to the foreign hospital, implant, and get the patient back to the University Hospital of Zurich. You can skip, Martin, and skip again. Thank you very much. Yeah, are we really just an ECMO team? That's a question what I already asked for about 2 years. I think it's not ECMO team. It's like actually more an MCS team right now, because our perfusionists in our hospital, we will do all kind of devices. So we do combination transports for ECMO ERBP or ECMO Impella, but patients, we do it in the jet, we do it in the helicopter, we do it a ground ambulance, and it's just handling all the devices. And the perfusionist seems to be a very good staff to handle all these devices. Also in our hospital, we are the experts for all these devices. And so the advantages of an experienced MCS team, actually mechanical circulatory team, is having a trained specialist staff like the perfusionist. The perfusionist is really an all-rounder. He knows a lot about oxygenators. He knows a lot about circulatory support. He's in our hospital 24/7 available. Also the heart surgeons and the ICU. We have very well good equipment. It's up to date. We have for every transport a concept, like for combination transport or transport on children, or transport with only one single device. Is it ERBP, Impella, or ECMO? We are actually a tertiary center, so a big ECMO center with a great caseload to about 120, between 120 150 cases, what makes us to a big center with a lot of experience. I think also the caseload in ECMO transport is enormous, because you need to have a lot of knowledge in that. And we are actually at the moment 10 perfusionists, and all 10 perfusionists are able to do transports. But that is the good thing with a high load on ECMO cases outside the hospitals or ECMO transport. Every perfusionist can get his knowledge better and better and better. And that is a team solution and not a one-man solution. And that's actually what we would like to do in Zurich, is that our 10 perfusionists all have the same quality, and everybody can do the same quality on transport. But for that, you need caseload and experience over several years, and not just once, and you do one transport in 1 year. Our material is pre-packed. You will see that later on. So if we get a call for ECMO implantation, we are very quick, and in about 10 minutes we could leave the hospital for that. Martin, you can skip. Skip again once a little bit. What I want to show, a good ECMO program, you also need very good, strong partnerships. And here in Switzerland, we have for ground ambulance, it's Schutz und Rettung. It's our solution if you have to go with the ambulance, because sometimes we have very bad weather conditions, so we have to go by ground ambulance. And For air solution, we always go with the jet or with helicopter, and it's always performed by the Swiss rescue helicopter service, Rega, called. And that are our two partners, and it is important to have always the same partners, because then you can keep a very high quality. Don't change your partners too often. It's not good, and your performance will be not that good. But you also have to have very good partners for the other hospitals. You're seeing here some other hospitals. Most of you will not know them, but at the end, smaller hospitals also need capability to go to a high ECMO center. And if you have a good talk with them and they know you will take over their patients, they can call you and we will go and get this patients to our center or our ECMO center. You can skip, Martin. Yeah, some recommendations, but we all have seen. I think it's very important, and we do it like this, but the ELSO also says the receiving facility is usually the transport team or own transport team. We, all the patients on ECMO running in another hospital, or we will go and get them by ourselves, and also the implantation of patients on other hospitals, we will go there and do it by ourselves, so that we can look that it is done probably from the beginning on. And also the Stockholm experience is what they say, actually transport should be done by high volume ECMO centers and not by centers who are doing maybe 1 to 20 cases in a year. You can skip, Martin. And a well-trained ECMO team is also doing a lot of simulation, and here you see all our surgeons doing an ECMO implantation simulation. It's an interdisciplinary team, and our chief on the left side, Francesco Maizano, is showing also to the younger surgeons, or maybe also to the experienced surgeons, how to do a safe cannulation of ECMO. And I think that are small things what really changes your outcome and your quality. If you train and train and train, you really can increase your quality in the ECMO therapy. You can skip, Martin.
Okay, thank you very much, Koen, for this overview. I think I will take over now and come back to the special situation in the COVID patients. As we heard now already from Koen, we have all our equipment ready stored in a room in the operation room. All the equipment is stored in 5 robust transport bags. Most often we are performing percutaneous implantation by punction of the vessel, and then we introduce the cannula by Seidinger technique. And you see all the equipment is stored in these bags, and these bags can be loaded and also transported very compactly here together, also with the Cardio-Halbe ECMO device. In the case when a percutaneous puncture is not feasible, or maybe you get complications by the implantation, we also always have one bag with us with a full surgical implant kit, as you can see there on the right picture. So we are always ready also to make a cut down, make a open exposure of the target vessel and make a normal open surgical cannulation, or in case you have rupture or perfusion, perforation of a vessel, here we also can interfere there on the surgical way. But of course, you cannot only think about the surgical equipment you need, you also have to talk a little bit about how to protect your team. Yeah. And here on 1st of April, I catched up a very interesting picture from the German news in the television. And there you can see how a team was doing an inter-hospital transfer of a COVID-19 patient. And what for me was very surprising, that you can see that all the people on these pictures are protected in a different way. Or you see on the one side the extreme version with people in a full body suite. And on the other hand, one man from the fire department who's only having gloves and a mask. Yeah? And so we also face this problem when we went out now to smaller peripheral hospitals, that in every hospital they had a little bit different standards and different equipment. And so we decided, in order that our team is protected always well on these missions, to prepare a personal protective equipment kit, yeah, where we have all the basic stuff inside to protect the team members. Yeah, it starts with a disinfection solution. Of course, you have the face mask. We are using here the 3M or FFP2 and 3 mask. You have once the long gloves, and then of course also sterile gloves for the surgical implant, and also to protect your mucosa and the eyes, goggles and body suite. Yeah, so this is everything also packed together in the bag. So when we go out to perform an implant, everybody from the team members is taking such a bag to be protected as much as possible. We also developed together with our colleagues from the anesthesiology and from the intensive care unit evaluation sheet, yeah, for preoperative assessment of the patients who are introduced to our center. Of course, in this sheet, we are taking the personal data so that everybody knows about which patients we are talking. We have the main characteristic like age, and what is also very important to already plan the implant, the high weight, and of course BMI and body surface area. And of course, when we are talking about indications, we also have to know about comorbidities. You also have to know how long is the patient already on mechanical ventilation, as this is also having impact on the outcome later. And when we are talking about VV or veno-arterial ECMO, you also must know how is the hemodynamic situation, is the patient already on catecholamines. So these are all the basic things we are collecting in order to discuss interdisciplinary then the indication, and if we would accept this patient for ECMO implant and transfer to our hospital. So like this, we have here the following contraindications I would like to share with you. So we were saying, as we were not knowing in the beginning how will be our resources here, yeah, that we will concentrate on this population who will have the best outcome, yeah. So we focused on younger patients with no or only less comorbidities. Of course, malignant or oncologic disease in palliative stage is a contraindication. Patient with already multi-organ failure or severe neurologic impairment is a contraindication. And of course, we also were saying that we will not do emergency implants, yeah, as this is already in a normal setting very challenging, and especially now if you have a isolated patient, yeah, I think it's also dangerous for the team when you are in a hurry. Maybe some steps with the protection are not well done, yeah, so that we also set in our center patients who are really deteriorating very fast and who are already on high catecholamines. We don't run into an emergency ECMO implant. So when you go there to the implant site, then of course you cannot take all your equipment you may need into the patient room, or because this equipment will be contaminated later and you have to throw everything. So from our point of view, good preparation is key to success in these cases. So as you can see on the left picture, we really only take the basic stuff inside the patient room, which we really will need for sure for the implant. Yeah. So this is, as you can see in the upper left corner, this sterile surgical cover to cover the patient after disinfection. Then, of course, a puncture set to perform the vessel puncture. Then you need, of course, 2 wires, one for the jugular vein access, one for the femoral access. According to this, also 2 different veins. And for VV ECMO, we also need, as you can see down in the picture, a small extension tube. And all the rest, which you will need, we prepare in front of the patient room, and we instruct a member from the local team in the hospital where we go, that in case we need additional stuff, we can take it out of the clean area and bring it into the isolation room. Yeah? For example, when a puncture is not going well, you maybe need a second puncture set, or when you have maybe calcifications, you need maybe a hydrophile wire, the Terumo wire, to pass this calcifications, or when you have problems with insertion, the cannulas, yeah, you have to change to a stiff or ultra stiff wire together with a catheter, and all the stuff we are preparing. And in case we need it, somebody will bring it to us. The ECMO setup, we use a cardio-help system with the HLS7 oxygenator and the cannulation. Max was already talking about it. In most of the cases, we prefer to do the femoral and jugular vein access. As we already heard in some patients, we have a high thromboembolic stage, that also catheter maybe, which will already lie in the subclavian or also in the jugular internal vein, may have caused there already thrombosis. Then another possibility would be to cannulate the femoral vein on the right and on the left side. For the cannulation, yeah, we don't recommend to take the dual loom cannula as well, because for out-of-center implantation, first of all, it's very time-consuming, and you for sure need the echo guidance or fluoroscopic guidance for proper cannula placement, and this you will not have in a smaller hospital. And of course, we also will have a higher thromboembolic risk, so that we don't recommend the cannula in COVID-19 patients. Also, when you have done successfully then the implant, also during the transport, of course, you must make sure that you consider all the hygiene measures to bring the patient and also the team safe to the hospital. And for the transport in the helicopter, you do it like this, that the patient is, as you can see in the picture down in the middle, is wrapped after implantation in a special folia, in a special cover bag, yeah, so that only the inside of this bag is contaminated, and we can go with the patient covered like this into the helicopter without contaminating the whole cabin of the helicopter. And after we had bring the patients then to our center, this coverage bag is thrown. And also with the equipment we have taken with us, if you have to transport it, the same cabin like the patient, make sure that your equipment gets not contaminated. For this, we store it in plastic bags, which are also after the transport thrown. When we arrive back to our hospital, it's very important to make again a checkup. We do an X-ray, yeah, to control if the cannulas are still in their position. Here you can see that during the implant or during the transport, the lower cannula was moved a bit too much inside the patient, like this. You risk to have a recirculation. And on the right picture, you see after optimizing the position by pulling back the cannula, you have again optimal conditions. Also during every shift, that means 3 times a day, we are checking the cannulas and looking that the implant length is still the same, so that there's no risk of dislocation from the cannulas. Some observation we have done in this 3 COVID-19 patients, I also wanted to share with you. The One point is for sure the already from Professor Lorusso mentioned prothrombotic hypercoagulative stage, which these patients are having. We also face the problem of pulmonary artery embolism, and for sure these patients need strict anticoagulation. Yeah, so also for patients with COVID who are not on ECMO, I think we cannot recommend only prophylactic heparinization. We have to go for full heparinization. But we also saw that some patients which were stable for some days really can rapidly decline and also get problems with the hemodynamics, as this disease is not only affecting the lungs but also the cardiovascular system. And then of course we have also to discuss how to upgrade our ECMO system then. On the right hand you see, I think, the most common setting then with a VAV ECMO, so that you introduce a third atrial cannula to have a pre-oxygenation in front of the lungs to make sure you have optimal conditions for lung recovery, and also to make sure that your coronary arteries and the heart is getting optimal oxygenated blood. Another solution would be a VV ECMO additionally with an impeller device. Of course, for this, we must have a adequate right heart function, and you also have to mention that the implantation of the impeller device is much more complex. Yeah, most of the centers are doing it in the cath lab, so it's also the question if you want to transport this kind of patients through all your departments. Yeah, but these are two options which we have discussed in our unit. And as I mentioned already, I would like here to share a special case with you, one on our patients on VV ECMO with COVID-19 also get a thromboembolic complication. Later it was also tested positive for HIT. And you can see here on the right upper picture or that after a while there was developing a huge thrombus, yeah, on the vena cava inferior, ranging into the right atrium, which you can see on picture D. And the CT scan then was also showing that this patient already had a central lung embolism. We were discussing what we can do, how to remove this thrombus in order to prevent further dramatic thromboembolic event. And we went to percutaneous thrombectomy by using the AngioVac device. The AngioVac device is a device which is looking similar to an ECMO. That means you also have an insertion cannula, which is having a suction umbrella on the tip, yeah. And with this cannula, you can go close to the thrombus formation. Then you can suck with a normal centrifugal pump this thrombus away from the vessels, and the thrombus will stuck then in a filter, and the blood you had removed, you have taken out of the patient, you can remove later through the normal ECMO cannula. And like this, we could take out this thrombus. In the first picture you see it's also marked the thrombus formation. And in the middle, you see the result after suction thrombus. The thrombus is away. You only see a very small adhesion on the vena cava. And in the filter, then you see the removed thrombus, which is already organized. So to come to an end, all of our 3 patients where we were performing the ECMO implantation in another referring hospital are doing well. They all could wean now from ECMO, but they are still on the ventilation, and we are looking forward how they will perform the next days. To conclude, we must say that the ECMO implantation in well-trained hands is a safe and feasible way to support patients with COVID-19. Of course, it is a time and also resource consuming undertaking. So for most of the patients, we were 4 to 5 hours on the road to make the implant and bring the patient back in the center. And as we already discussed, yeah, the implantation should be performed by an already well-trained and established team. At the out of center implantation is also a little bit more challenging, or you have not the normal team, the normal nurses, your normal echocardiographer. So also in case complications are happening, you have to handle them your own. So I think it makes only sense to start such programs with a really well-trained team. And maybe Koen, also from your experience, you also want to tell us some take-home messages.
Yeah, what I would just want to say, I mean, ECMO is a very good bridge therapy, or the devices are a very good bridge therapy. I think for a successful transport program, you need very good cooperation, and it will be very important for you if you want to do or act a ECMO implant system in for peripheral hospitals. You need to have enough caseload, otherwise you will not learn a lot. And I think early contact for ECMO center, that is something what is always good. And our peripheral hospitals know that we have a very good, well-trained ECMO team that will come to them. And it takes about 4 or 5 years until the other peripheral hospitals will get the knowledge that they can call you as a ECMO specialist, that we can come for selective patients for implant. Yeah, and that is what I wanted to say. Thank you very much.
Yeah, I think then we can close our talk. Thanks a lot for your attention, and I will give back to the moderators, and I think maybe we are open for discussion now.
Thanks both of you guys for your presentations. Everything was wonderful and we've learned a lot. One of the first questions we have is from an anonymous attendee. I think this probably goes to Max. Do you have any experience with increased coagulation events in the COVID-19 patients compared to the other patients that you've treated before with ECMO?
Yes, the anticoagulation, I think that's an open question to everybody, but I think we need more than 10% more heparin than usual. And it's a recommendation that you use more heparin as usual because the anticoagulation is tricky. Roberto, what do you think?
Yeah, I agree. I think that you must be careful in this patient, particularly for, as you heard about thrombosis of the system. Although the vast majority react as normal ECMO patient, I think these patients have, I mean, a sort of, they are prone to get thrombosis even on ECMO. So acute pulmonary embolism can occur even on ECMO. So as soon as you have unexplained desaturation, so you check your system, if your system is working well, you have to even go to CT because it can be that you can have a pulmonary embolism. So I agree with Max, you have to use a little bit higher anticoagulation in this patient. Maybe you can use some fraction heparin together, but for instance, I would not really recommend to use alternative to heparin like bivalirudin. I think bivalirudin in this situation with such a high prothrombotic state, I would not use it. I think the chance for acute thrombosis in the system, only the pulmonary arteries could be higher. We have of course, no clues, but I would not use like bivalirudin in these patients.
And we have a question from Maureen Gray, and this is interesting. After looking at your graphs of the decrease in cytokines, is there a rebound of the cytokines after a week of running it? So do you run the Cytosorb filter for a week and then look at the cytokines, see how low they are, and then do they start rising after you take the filters out?
I think we are not able to say that right now. We have to wait another weeks and another moments to get a conclusion for that. The storm of cytokines is when you start with the ECMO and when the infection is there and you are able to treat them well with the adsorber. But I think we have to wait another weeks or maybe months to answer this question. Koen, what do you think?
Sorry, I'm reading some other questions. Can you repeat real quick?
Just wondering if you saw a rebound of cytokines after you stopped using the filter.
I think it's at the moment it's just too early to say. I mean, we have to wait for some other data, but you cannot, after 3 weeks, we cannot say about, especially on the COVID patients, we cannot say it. I mean, we're using the Cytosorb also in other patients, but at the moment, I just have to say we have too less data for that, and some data are still in the proof at the moment, and we will show what it's going to be, but I have no idea at the moment, really.
In my point of view, I think it's clear that COVID patients, as compared to other outbreak patients, have a higher rate of, for sure, very severe, serious reactions during the disease. Therefore, I would say that of course, you have to monitor closely. But if you can see that you have the so-called cytokine storm, maybe that's the moment to start thinking at least about the use of filter. So I think we have to monitor your patient, that's for sure.
I mean, I've seen some other question. Somebody wrote, when is the right time to start? I think that is also something to answer as soon as possible.
Absolutely.
Don't wait too much. If the patient is already getting bad, you are already too late. So also on COVID patients, I think it makes sense to start very early with Cytosorb. That's my opinion.
I mean, it can also be a method in order to save catecholamines. Or we also saw in some patients when we start with a therapy with a Cytosorb filter that you really already after a few hours could start to reduce vasopressors. Yeah. So it also can be maybe a method in order to prevent borderline patients going on VA ECMO. Yeah, but of course it's too early to say. But this is also something we had seen.
Thank you. We have a question from Christos Kalaritas. Our nephrology colleagues are stating that these Cytosorb filters clot off easily and have told our ICU colleagues that they are not a good choice. Do you have any experience seeing these clotting off?
Sorry, I don't get the question. That the Cytosorb clots.
Yeah, that's what she probably means is that the Cytosorb really often clots in the hemofilter system. And our experience is sometimes, or if possible, we do it in the ECMO circuit. So we have a very good flush of the Cytosorb filter with about 500 to 600 milliliters per minute. Then we usually don't have very big problems with clotting of the filter. But if the filter is running in the hemofilter system on the ICU, and you have a very small blood flow of about 100 milliliter, you've seen more and more that they clot. Yeah, that's also something what we have seen.
I have not personal experience in this respect, but I had some information coming from North Italy where they had really a major impact, and a group of nephrologists exactly use the Cytosorb in a series of patients with some good results. This paper is going to be published, I guess. I got only the preliminary, again, comments, but there is, so if they think that could be useful, means that the case series was not certainly negative. The paper is under publication.
Thank you. I have another question from Jonathan Akay. Which is more acceptable to use to measure do you want to measure the ACTs or the APTTs? What range do you want that at to make sure the anticoagulation is acceptable during the ECMO run?
Yeah, we normally recommend ACT level more than 180 seconds, or let's say between 160 and 220 seconds. And I think that's reasonable. In
Yeah, I agree. I mean, you have to be higher than usual. So usually stay with 160, 180. I think 180, 200 is more recommendable.
Ian Shearer wants to know, what was the average hours of mechanical ventilation support before you typically had to initiate ECMO?
Yeah, this was shown on the first slide. Yeah, so all patients were 6 days, 5 to 6 days before ECMO implantation on mechanical ventilation support, and they were around 1 to 2 weeks in the hospital. And onset of symptoms was 2 to 3 weeks before ECMO run.
Do you feel like that you could have shortened that time, been on the ventilator less time, and initiated ECMO earlier?
Definitely. If you wait too long, then the patient could be really in a refractory state, and so irreversible end organ damage, and therefore ECMO in that case becomes futile.
Yeah, I mean, this was actually what happened, or why we had to go and take this patient and perform the ECMO implant in the peripheral hospitals, or because the patient were not anymore in a transportable conditions, or they were already 1 or 2 days turning them to get better ventilations. And so I also agree that in these patients, maybe they should have referred the patient 2-3 days earlier. Yeah.
But I think personally, we have to have a very clear look on the indication and also on the contraindication, because what I showed you before was a curve of the Spanish flu. We don't know what we get faced with. So I think the indications are very important, and also the timing is very important. Not too early, but for sure not too late, but not too early. That we have to have a look for our resources.
Thank you. Next
I also
today,
think with the indication, sorry, is also something every country and every center really has to vary also a little bit according to their local possibilities. Yeah. So, for example, here we were very lucky till the moment, or that we really were prepared for much more cases. Yeah. So we had the luxury to spend a lot of time and resources to do this ECMO program. Yeah, but of course, if you don't even have enough ventilator capacity or nursing staff taking care of the patients, of course, you have to reconsider under ethic aspects also the question if you can afford to make ECMO implants, yeah, which are time, resource, and personal consuming. Yeah, so I think it's also something we have to adapt always a little bit on the actual situation. Yeah.
okay, thank you. We're actually about out of time. Thank you again for joining us for today's webinar. The recording of this webinar will be posted on jointperfusiontaskforce.org within the next 2 days. All attendees of the live broadcast will receive access to a brief survey to claim credit for your participation today. If your question was not addressed, please consider posting it to the discussion forum for input from members of the task force and from other perfusionists from around the world. And we will be trying to post some of these questions that we did not get to on the forum as well. Our next webinar is scheduled for May 14th. We hope you'll join us. Thank you.
Yeah, thanks.
Bye.
Thank you.
Yeah.
Thanks so
you,
much,
everyone.
gentlemen. Thank you.
Thank you
Thank
so
you for
much.
joining, and happy Perfusion Week to all of the perfusionists around the world. Stay safe and be well.
Thanks.
Bye.
Thank you.
Bye.
Bye.
Bye-bye.